Bismillah ar-Rahman ar-Rahim. Today we'll talk about nephrotic syndrome. It's mainly composed of three important presentations. Thus we say called tetrad, that is the hypoalbuminemia, edema, and proteinuria. And the patient was represented with features of fatigability, malaise, anorexia, and complaining mainly of the distension of the abdomen and the swelling of the lower limbs, and that may extend up to the genitalia. Before we go into the nephrotic syndrome, first we need to explain the main pathogenesis, and to explain that we need to go through the anatomy and physiology of the glomeruli. Each glomeruli is containing inside it a glomerular tuft, which is composed of filtrated glomerular capillaries that is supplied by blood via the efferent renal arteriole, and the blood come back to the circulation via the efferent renal arterioles. And then the filtrate is going to go to the proximal convoluted tubule, and then from the proximal to the descending limb of the hilly thick and thin segment, and then the ascending thin and thick segment, distal convoluted tubules, and then to collecting ducts. What happens in patients who have nephrotic syndrome? The main thing in the nephrotic syndrome, if we look at here, there is damage to the component of the glomerular capillaries that will lead to leak of the protein, and sometimes because of the damage of the basement membrane or the endothelial or the podocytes, which are the main component of the glomerular barrier, filtration barrier, lead to the leak of the protein that in nephrotic syndrome will exceed 3.5 grams per 24-hour per square meter of 1.73. And with it, there will get hematuria in the excretion and lipiduria. So if we take a cut section in the glomeruli, we can see this is the glomerular Bowman capsule and the glomerular tuft, composed of two components of the afferent renal arterioles and efferent renal arteriole, and the blood is coming and passing through this fenestrated capillary, and it will undergo filtration of the plasma minus protein. And if we take a section of this glomeruli, you can see that the inside the glomerular, normally there is the glomerular capillaries, which are fenestrated, and the fenestra size is smaller than the size of the blood cells and protein. So no platelet or white BC or RBC is going to be filtered via these fenestration, and no protein also is filtered. So the size is important. And the second thing important is the negative charge of the photoprocesses of the podocytes, which are containing, this is labeled as a green extension of the photoprocesses, and the protein which is going to here, if it passes via the laminated glomerular basement membrane, then it will be expelled by the negative charge and it will be kept inside the circulation. So normally no protein is going to be lost inside the Bowman capsule, and the blood will take back the protein and the cells, and only the plasma minus protein is going to be filtered via this barrier. So we have a barrier which composed of this podocytes, and we have, in addition to the podocytes, we have the basement membrane, and we have the processes of the we have the endothelium with their fenestra that is going to filter these fluid. So we say that the glomerular basement membrane the podocytes and fenestrated epithelium, and in sequential layers we have the fenestrated endothelium, we have the glomerular basement membrane, and we have the podocytes and their photoprocesses are the main component of the glomerular filtration barrier. If we took to this afferent arteriole, this is the one that brings the blood, and this is important because the effect of certain drugs and certain hormones is mainly on afferent or efferent. So we say anything which is efferent is the one that brings the blood, which calls it the admit, means the afferent, and the exit, it means the efferent arteriole, and this is to keep it in mind for long-term memory. So next is to explain what is these layers. The barrier for the RBC and the protein, as you see, is the small fenestra, the basement membrane, and the podocytes, which is containing the negative charge. So this is the barrier, as you can see here. And what happens in cases of nephrotic syndrome, we are going to get loss of these podocytes, and sometimes may effaced with the basement membrane, as you can see here, and the fenestra may get large, and the negative charge, because the podocyte is lost, the negative charge is lost again, and so the protein can pass, the RBC can pass, and even other substances can appear like fat and so. So how can we explain? So by that we can understand what is the main problem. How is this going to be damaged by the deposition of either in situ immune complex formation or circulatory immune complexes which containing immunoglobulin complement that are going to be deposited in this tubule and damaging it. So if we are going to classify nephrotic syndrome and say that nephrotic syndrome is mainly classified into primary and secondary form of nephrosis. I'm talking now about what is the primary. The main three types of the idiopathic nephrotic syndrome is the one which is the minimal change disease. It occurs in children in 70 to 90%, and usually when look at it at light microscope, it's look like a normal, so call it nil disease. And in immunofluorescence study of the renal biopsy, we can see occasionally immunoglobulin M deposited in the glomerular basement membrane, but we can see that the podocytes are going to be effaced together with the basement membrane, losing the negative charge, allowing the protein to escape and to be deposited, as you can see here, via this lost and effaced podocytes. So the main problem is the podocytes in minimal or in null chain disease. While the second type of the nephrotic syndrome of the idiopathic is the membranous nephropathy, which mainly occur in 30% of nephrotic syndrome in adults. Here we can see in light microscopy the mesangium is going to be expanded, and the glomerulus is also expanded, and there is subepithelial, you can see subepithelial deposition of spikes, and this is seen only by light microscope, where it's seen like a subepithelial hum deposition in the which is just nearer to subepithelial deposition of a hum-like material, and in the light microscopy, immunofluorescence is not that significant, but may show deposition of complement and immunoglobulin, complement T3 deposition, and in in electron microscope we can see the basement membrane is get thick, and there is a spike of deposition of this subepithelial deposit. So the same thing happen in cases of focal segmental glomerulosclerosis, which could happen in pediatric and adult, but here there is a focal area of the glomeruli affected, and a segment of the glomeruli is going to be affected by the thickening of the glomerular basement membrane, deposition of immune complexes, and the development of nephrotic syndrome. So this is the main three components, which are the minimal chain disease, membranous glomerulopathy, and focal segmental glomerular sclerosis. If we come to say what is the type of secondary nephrotic syndrome, the main important types is the diabetic nephropathy, and if we found that diabetic nephropathy is the most common cause of secondary nephrotic syndrome, and even it's the most common cause of chronic kidney disease in the world, and lupus nephritis, and amyloidosis, and post-infectious, and that could be after development of hepatitis B or hepatitis C infection. Now, what makes the edema in these patients? Why edema develop? Edema is developed because there is a balance. This is the mechanism of the edema. You know that there is hydrostatic pressure inside any vessels and oncotic pressure. And if we come and we found that this is vessels, and this is intravascular space, this is interstitial space, and third spaces. What happened? The hydrostatic pressure normally is because of the pressure of the heart and the blood pressure. This is going to push the fluid outside the vessels to the interstitial spaces and intracellular spaces. While the oncotic pressure, which is contained by the negative charge of a protein, what we call also osmotic pressure, is going to pull the fluid and to keep it inside the vessels. And normally there is a balance according to the Stirling law between these two forces that make the amount of fluid goes to the cell is minimum. So if this is lost, as for example, when the oncotic pressure, this is the issue of nephrotic syndrome, is going to be decreased because we are losing protein and getting hypoalbuminemia. So we will get here a small force that keep because of the protein is low and the force here is big. So the net is the fluid which is going to be lost into the third spaces, and this can be inside the lung, whether in the pleural place, inside the pleural place, in the lung, or even in the pulmonary edema in the base of the lung, and maybe accumulated here inside, and maybe get around the heart in big pericardial effusion, and around the eye and orbital edema, and even in the lower limb, in the hands. And the net, if it is increasing, it will get total edema of the body, what we call it anasarca. So what other important thing is that this is protein which is going to be lost. This protein that is going to be lost is sometimes stimulating the liver. So the liver is going to be stimulated because this is partially is component of lipoprotein. And when the liver senses that the protein take the lipid and lost in the urine, so no more complex of lipoprotein, and the liver will sense it and will start to secrete cholesterol and very low density lipoprotein and low density lipoprotein. So we'll get hyperlipidemia. And this hyperlipidemia may result in excess in lipiduria. So here we are going to get accelerated atherosclerosis for this reason. On the other hand, the patient tends to be hypotensive because of the most of the fluid in nephrotic is going to be lost inside the third spaces and interstitial spaces. And the other thing is this is the immunoglobulins that are mainly IgG, IgM, and so this is mainly our globulin, and because of its loss in the urine, the patient immunity is getting down and expose the patient to infection. One more thing is that there is a loss of the antithrombin 3 being a protein albumin bounded, and the albumin is not here, so it will become free and it will be lost in the urine. And also the antithrombin 3 and plasminogen, plasmin also, or these are going to be lost in the urine. On the other hand, the liver will synthesize more factor 3 and factor 7 and prothrombin, and the result here is hypercoagulability, and the patient may present with nephrotic syndrome and so on. If this proteinuria continue and the disease process progress without control, patient may pass into acute kidney failure and chronic kidney failure. So this is another complication that can happen in those patients and patients with nephrotic syndrome. Thank you.